I'm going to be talking about the management of intra-abdominal hypertension in the ICU, and I'd like to frame it in the context of a case. So my question to you is, have you cared for a patient like this, a patient who has, on this X-ray you can see basal atelectasis. This patient came in with a distended abdomen, has low lung volumes, has elevated CO2 and low PaO2, has a tense abdomen, decreasing urine output, has required lots of fluid resuscitation, has metabolic acidosis, and has increasing vasopressor requirement. And I'm sure all the experienced clinicians in the room have. And we'll talk about how this case fits into the diagnosis of intra-abdominal hypertension and abdominal compartment syndrome. I'll start by reviewing the definitions of intra-abdominal pressure, intra-abdominal hypertension, and abdominal compartment syndrome. We'll talk about the different ways of measuring intra-abdominal pressure, talk about the incidence of IH and ACS, pathophysiology, evolution, and impact on major organ systems, and then move on to management and outcomes. So what is intra-abdominal pressure? It's the steady state pressure concealed within the abdominal cavity. It should be measured at end expiration in the supine position with absence of abdominal muscle contraction and with the transducer zeroed at the mid-axillary line using a closed and debubbled system. And these are recommendations derived by consensus by the World Society of Abdominal Compartment Syndrome. So this is a pressure that unless we measure it, we don't know what it is. It's like not knowing a temperature or not knowing a blood pressure. The normal IAP is 5 to 7 millimeters of mercury in adults and 7 plus or minus 3 in children. What's intra-abdominal hypertension? It's sustained or repeated pathologic elevation of IAP over 12 millimeters of mercury. Before we move on to ACS, it's worth reviewing the definition of compartment syndromes in general. And that is an increased pressure in a confined anatomical space which affects the circulation and threatens the function and viability of the organs that are concealed within that space. So then abdominal compartment syndrome is defined as a sustained intra-abdominal pressure over 20 millimeters of mercury with or without abdominal perfusion pressure of 60 millimeters of mercury. That's associated with new organ dysfunctional failure. So what is abdominal perfusion pressure? So if we look at this continuum from a patient who has normal intra-abdominal pressure to abdominal hypertension, and then with increasing pressure, abdominal compartment syndrome. Abdominal perfusion pressure is the mean arterial pressure minus the IAP. And this is sort of like the cerebral perfusion pressure, where we use mean arterial pressure minus the intracranial pressure. So this is the pressure which determines the perfusion of the abdominal organs. And once this pressure rises beyond a critical level, once the IAP rises beyond a critical level, the abdominal perfusion drops and there's reduced blood flow to the organs and end organ injury. So how can we measure intra-abdominal pressure? There are ways to measure it directly by using a catheter in the peritoneal space, or indirectly using intragastric or intravesical or through the bladder. So that's actually become the most commonly used method, and there's no difference in these methods between children, and that's been studied by a couple of investigators listed here. This is the system we use at our hospital, and they actually, I saw yesterday that they have a display at booth 72 and 73 if you're interested in looking at it. But it has, this is your Foley catheter connects to this system, which essentially provides a fluid column which connects to this pressure transducer and a monitor cable which displays on your monitor, much in the way we display arterial pressure or CVP. And just like with arterial pressure or CVP, there has to be a continuous column of fluid. So if there's bubbles or debris in there, that's not going to work. And you don't have to use a system like that. Our friends in Thailand came up with this homemade device where they have the Foley catheter, a little adapter, a 14 French suction catheter that's cut so it can connect to a 3-way stopcock, and then a pressure tubing which can be connected to a transducer. And as long as you can provide a fluid column, you can then measure the bladder pressure by turning the stopcock one way or the other. So what is normal IAP in children? We investigated this by obtaining a compliance curve in 96 mechanically ventilated patients in our ICU. And what we did was we put in graduated amounts of saline into their bladder. And this was a compliance curve where we were able to find a minimum optimum volume as well as a mean optimum volume. And what we found was that the minimum optimum volume is 3 mLs in children, or 1 mL per kilo up to 20 kilos, and that's the recommendation by the World Society of Abdominal Compartment Syndrome. We also were able to establish that the normal pressure in children is 7 plus or minus 3 millimeters of mercury. So that gives us a reference point on where to define intra-abdominal hypertension in children once we know what the normal is. In a separate study, we were also able to establish that positioning the head of the bed affects the IAP reading. So again, the recommendation from the World Society of having the patient supine is sound. And the body mass index, unlike in adults, it does not affect IAP in children. You may ask, can we just assess this clinically? And the answer is no. This was studied in Canada as well as Australia. And when the IAP was over 10, the clinical exam sensitivity to detect IAP elevation was 40%. It went up a little bit with IAP of 15, and even a little bit more with IAP of 18. But essentially, it's no better than a coin toss. So clinical assessment is not accurate and cannot replace measurement. What is the incidence of intra-abdominal hypertension? In adults, this was the most recent study, prospectively looking at IAH in a medical surgical ICU. 31% had it on admission, but 33% also developed it later. The patients with IAH had a higher mortality, higher SOFA scores and renal failure scores, and cumulative fluid balance. Importantly, the maximum IAP was an independent predictor of mortality. ACS was seen in 12%, but abdominal compartment syndrome had a very high mortality in adults. How common is IH in the pediatric ICU? If you only measure patients who have a distended abdomen, these two studies found that it was about 1%. But progression to abdominal compartment syndrome, even in this series, had a 40 to 60% mortality. But they probably missed a lot of patients that had IH elevation, because as I've shown you, the clinical exam, or if you wait to look at an increasing abdominal girth, it doesn't tell you what the intra-abdominal pressure is. We screened 294 consecutive ventilated patients in our ICU. We were able to get consent from only 75 to study this, but we found that there was IH in 22% of that 75 and ACS in 14 of those patients, which overall is 4.7% when we look at the total population of ventilated patients. But again, an extremely high mortality, 50% in those that had abdominal compartment syndrome. The intra-abdominal pressure and ACS were both independent predictors of mortality, and intra-abdominal pressure and the PRISM score being over 17 were predictive of getting ACS. I'd like to spend a few minutes talking about the pathophysiology before we talk about the management. So this is a CAT scan showing that with the diaphragm elevation and increasing abdominal distension, there is basal atelectasis. There is decreased functional residual capacity, which promotes ventilation-perfusion mismatch. The elevated diaphragm promotes atelectasis in lower lobes. There is neutrophil activation and increased extravascular lung water. There is decreased compliance or increased chest wall elastance. So if the IAP is over 16, there is a 50% decrease in chest wall compliance. And there is flattening and rightward shift of the pressure volume curve. In this study, Gattignoni and colleagues were able to show that once the IAP was over 16, there was a pathological increase in the chest wall elastance, which, as you remember, is the reciprocal of compliance. So the chest wall compliance markedly decreases when the IAP exceeds 16. And this was in centimeters of water, which is the same as 12 millimeters of mercury. And keep this number in mind because we'll come back to this number several times during the talk. What about the cardiac effects? We see that the cardiac index drops and the wedge pressure increases as the abdominal pressure increases over the baseline. This is related to reduced venous return, increased systemic and pulmonary vascular resistance. The mean arterial pressure initially increases because of the increase in systemic vascular resistance, but then decreases. There is an increase in the pulmonary artery pressures and a decrease in the left ventricular compliance and regional wall motion. Also, clinically at the bedside, the preload assessment is difficult because both the CVP and the pulmonary capillary wedge pressure seem higher than they actually are. How about the renal effects? This was demonstrated back in 1947 in this paper in the Journal of Clinical Investigation, where these investigators had 17 normal adults, and they put tight binders around their lower abdominal wall and looked at renal plasma flow by looking at hip urate clearance, inulin clearance, as well as the urine output, which is down here. So if you look at this, you can see that the renal plasma flow as well as the glomerular filtration rate drops, and you can see the drop in the urine output from 9 cc's to 3 to 1 in this individual, and this is a healthy volunteer. In a patient with the retroperitoneal hemorrhage, you can see on this CAT scan that the kidneys are compressed, the IVC is flattened, the abdomen looks round and not oval. This patient has abdominal compartment syndrome. The other intra-abdominal organs are affected too. This was studied again in normal patients undergoing laparoscopic surgery, and as the intra-abdominal pressure is elevated, you can see that the mucosal oxygen saturation drops from a mean of 69 to 63 to 54, as well as hepatic arterial flow, portal venous flow, glucose metabolism, lactate clearance, all of those drop. Capillary leak worsens, and bacterial translocation becomes an increasing problem. Increasing IAP also has effects on intracranial pressure. In this study with moderately ill neurotrauma patients, they put a 15-liter bag on the abdomen, and immediately you can see a rise in the CVP, a rise in the intrajugular pressure, rise in the IAP, rise in the intracranial pressure. Thankfully, the blood pressure went up too, so the cerebral perfusion was maintained. This kind of ties it together. Raised intra-abdominal pressure reduces diastolic pressure in IVC, reduces venous return, leading to cardiac output decline and potentially cardiac failure. There is also increased systemic vascular resistance, again putting the heart at a disadvantage. We have reduced plasma flow and glomerular filtration, leading to renal failure, renal arteriolar and venular compression, leading to hypoxia, reduced lung capacity and compliance, which leads to respiratory failure, reduced GI mucosal function, leading to bacterial translocation. So 3 or 4 days away from Valentine's Day, where you may have thought the heart was the center of the universe, it's actually the abdomen, because being in the center, it can affect all these organs, including the brain. Let's move on to classification and causes of abdominal compartment syndrome. Primary ACS can be from any abdominal pathology, which can be retroperitoneal, such as pancreatitis, intraperitoneal, which could be from bleeding, obstruction, perforation, intussusception, abdominal wall problems like burns, eschars, gastroschisis or omphalocele, reduction of large hernias, and so on. So that's defined as primary ACS where there is a primary abdominal problem. Secondary ACS is due to ischemia reperfusion injury, and this is probably something we see in the ICU with shock resuscitation for sepsis, trauma, and burns. Recurrent ACS is the third, also used to be called tertiary ACS, which is recurrence of ACS after primary or secondary ACS is treated. In children who needed abdominal compression, in the study in 2000, the most important cause was necrotizing enterocolitis, also perforation, Hirschsprung's, trauma, and small bowel obstruction. So which patients are high risk for ACS and should be monitored? Those with diminished abdominal wall compliance, increased intra-abdominal contents, increased intraluminal contents, or capillary leak. So these are the broad categories of patients that should be monitored. How about in our units in the pediatric and neonatal ICUs, which patients should be monitored? Perhaps based on our studies, if they are more than 5 liters or more than 10% of body weight fluid overloaded, those patients are at risk for IAH and ACS. What level of IAP should be of concern? In this study with over 500 newborns and children undergoing laparoscopic surgery, Baroncini demonstrated that there is impact on cardiopulmonary function in newborns at 6 millimeters of mercury and in children at 12. So again, we hear that number of 12. We had shown that 7 plus or minus 3 is normal. If that's true, that's normal, then treating more than 12 as abnormal seems reasonable. And that should be a level that we should worry and monitor those patients more often. So what can we do? We can monitor them serially, at least every 6 hours, more often if we're actively fluid resuscitating them. We need to be able to recognize IH and then manage them medically and surgically. What's the medical management? Consider bed positioning, consider making them fully flat, or reverse Trendelenburg, balancing the risks of VAP. Use sedation and pain control because often that's all that's needed. Because if there's abdominal wall muscle contraction or the patient struggling against the ventilator, the intra-abdominal pressure goes up. Fluids, enough but not too much. You can use pH, lactate, SpO2, or other surrogate endpoints. Think about limiting or concentrating the drips, using colloids or hypertonic solutions, and this has been shown in 2 randomized trials in burns patients to be an effective strategy. Try to maintain an adequate abdominal perfusion pressure. Unfortunately, we don't know what that number is in children, but using a number similar to the recommendations for cerebral perfusion pressure seems reasonable. Use nasogastric tubes, cathartics, rectal tubes, or enemas to decompress the GI tract. You may have to use paralysis, again balancing the risks or benefit. And we can drain fluid if there's free fluid within the abdomen using a peritoneal catheter. And if the patient is fluid overloaded, say day 1, day 2, day 3, diuretics or CRRT, which Dr. Zimmerman will talk about, are options as well. So this is the medical management algorithm recommended by the World Society. And I made copies of the assessment and management algorithm, and they're in the back. There's a chair in the back with 50 copies over there. So if you'd like, you can grab one on your way out. And it kind of goes through stepwise what to do in terms of evacuating intra-abdominal contents, intra-abdominal space occupying lesions, improving abdominal wall compliance, optimizing fluids, and optimizing systemic perfusion. And it goes through a series of steps. But if that fails, then surgical management should be considered, surgical decompression. So I'll show you a couple of medical management where it's helped. So here you see the intra-abdominal pressure, and you see that urine output's low. Cis atracurium is given. This was an adult patient, and you see the urine output jumps up. It lasts for a little while. Urine output drops again. Now they start the patient on a cis atracurium drip, and you see the urine output's much better maintained now. In cases with pancreatitis, there was a randomized control trial done for percutaneous catheter decompression versus conservative measures, showing that on day one, they were able to drain 1,800 cc's on average. This is in adult patients again. The intra-abdominal pressure dropped, and there was a decrease in mortality in these patients as well. Delay in abdominal decompression can lead to intestinal ischemia, so we should decompress early. Our surgeons like to leave the fascia open, use the omentum to cover the viscera, use a shear of clear plastic or silicone, and use some tubes that are placed under the fascia but over the plastic and iodophore impregnated adhesive plastic tape. And I know there is a session on surgical management tomorrow, so I'm not going to go into much more detail other than to show you a picture of each of those steps with the clear silicone there, and then the drainage tubes for suction, and then the iodophore impregnated sheet that goes right on top, and that's what the patient looks like. People have also used vacuum-assisted wound closure, and especially in patients who have difficulty because of adhesions or fascial retractions, that's been shown to be pretty effective. So does IAP-targeted management make a difference? In this study in 1993 in the Journal of Pediatric Surgery, they monitored intra-abdominal pressure in 42 consecutive newborns with omphalocele or gastrocesis, and they kept the IAP less than 20. They delayed initial closure, used sedation, paralysis, postponed siloreductions. All of these patients survived to discharge, and none of them had acute renal failure. So using an IAP-targeted management made a big difference in this series. A more recent paper suggests that it may be important for NEC development. Again, a pressure over 12 in 4 babies that got NEC and 4 controls. So again, a very small study, but that's what it shows. Should we intervene even earlier? In this study with 26 children with oligurin high vent settings, they decompressed after the ACS developed, and IAP was high, 58% mortality. The survivors had lower IAP. This study decompressed much earlier, IAP over 12, and 1 organ dysfunction, only 21% mortality. So maybe we should be decompressing even earlier. So I would like to summarize the approach to IAH and ACS as intra-abdominal hypertension is an urgent medical disease, and abdominal compartment syndrome should be treated as an emergent surgical disease. Keeping in mind that the abdominal pressure, perfusion pressure is lower in children, though we don't know what numbers to shoot for just yet. So in conclusion, we can monitor IAP easily by 1 mL per kilo up to 20 kilos, or just use 3 mLs. That's enough to create a fluid column and give us a measurement. Normal is 7 plus or minus 3, IH if over than 12. Prevent IH and ACS. Okay, my time's over. And remember to go from medical to surgical management in a timely fashion. Thank you for your attention. I'll be happy to answer questions.